Yeah, today we'll be showing endovascular embolization of brain arteriovenous malformation. We had a young boy who presented with severe headache, vomiting, and CT scan showed intracerebral hemorrhage. In such patient, it is important that we should do a distal subtraction angiogram. So we had done an angiogram. This is an angiogram run, which is showing a frontal lobe AVM. So this AVM we need to treat. So this is another view. So for brain arteriovenous malformation, there is three types of treatment. One is from endovascular, we can do glue embolization. Second thing is open surgery, and third option is radiosurgery. So because this is a ruptured AVM, we need to do either embolization or surgical excision. Earlier, embolization was to help surgeons to do excision. Now we can do curative embolization. So today I will be demonstrating one of the method called modified pressure cooker technique, by which we can do cure the AVM. So this is an angiogram. So here this is a roadmap. Using the roadmap, we guide the microcatheters. In the modified pressure cooker technique, you require two types of catheters. One catheter is a detachable catheter. You can use either Sonic or Apollo. And the second catheter is used to inject histocrit glue. So that will block the reflex of the onyx into the feeding artery. So here we are taking the detachable catheter into the feeder. So this is a different views where we need to negotiate the flow directed catheters. These are detachable catheter. We are taking into the anterocerebral artery, the feeding artery branch. And I think sometimes it is difficult for us to navigate into the A1. So if one catheter goes, so the second catheter we can ship in easily. Sometimes we may use, sometimes we use a balloon to help to navigate into the feeding arteries. So here we are taking the detachable catheter into the feeder near to the nidus. So here you can see there are two markers. One is the distal one and proximal one. So this is the detaching zone. So from here to here is the catheter where we can take the reflex. So we are taking the microcatheter shoe to demonstrate the nidus and the AVM, and we are near to the nidus. Now we are taking the second catheter, which was a marathon, non-detachable. So once the first catheter is in, to take the second catheter, it is very easy because usually the second catheter follows the first catheter. So we take this catheter at the midpoint of the distal and the proximal marker. So this is the midpoint. So we need to take the second catheter in this time. So after this, we'll be flushing the detachable catheter with the saline, and then we'll be injecting DMSO followed by onyx. So here we are taken a shoot from the second catheter. So now we are injecting the embolic agent, onyx embolic agent. We inject very slowly, depending on the flow, whether we can take 18 or 34, we need to decide. And so here we are injecting. So now the onyx is reflexing into the detachable catheter. So once it starts reflexing, we stop the onyx and inject glue in using the second catheter and block the reflex. So now the reflex is blocked. We put the glue and retrieve the catheter, and now we are continuing using the onyx or squid, any embolic agent. We can continue. So there won't be any reflex of the agent into the feeding artery. And so this is the detachable marker which is far away. And you can see now the embolic agent is going only antegrately. So there is no reflex. And once it is completely embolized, we can slowly pull the microcatheter and the AVM is cured. So this is how we can do curative embolization of a ruptured AVM by using modified pressure cooker technique. Thank you.